ડોક્ટર વિતરાગ સર, આપણે 10 સેકન્ડમાં ચાલુ કરીએ છીએ.
ઓકે.
Shall I start? Very good afternoon to all the viewers from GSFPF and AFPA. It's a great pleasure to have you all with us today for this very interesting webinar on preventing ICU admission at community level. With us today, an eminent speaker from Surat, Dr. Vitrag Shah. Dr. Vitrag Shah is a renowned physician and chief intensivist from Velocity Hospital, Surat. He has done MBBS and MD medicine from GMC Surat. After MD, he underwent ICU training at KEM Hospital, Pune. He has done his super specialization in FNB critical care from Sir Gangaram Hospital, Delhi. He has also cleared European diploma in critical care from London, UK. He is very much interested and expert in diagnosis and solving the rare cases. He is well versed and skilled with all the ICU procedures, always staying updated, well versed with latest guidelines. He presented several papers and posters in local and regional conferences and won awards and prizes as well. His vision is to improve the level of critical care, ICU care in all parts of the India, including the periphery, by improving the education and raising awareness about the critical care. Now I request Dr. Vitrag Shah for delivering the talk on topic preventing ICU admission at community level. Dr. Vitrag Shah, sir.
Thank you for the warm introduction, Dr. Dhirendra sir. So without wasting further time, I will start with interactive case discussion. Let me share my screen. Is it visible now?
Yes, sir. It's visible.
Okay, just. Okay, so it will be interactive case discussions. There are 9 to 10 cases, and all are actual live cases, not dummy cases, which I have encountered and which we can prevent with certain good practices, and we can prevent such ICU emergency admissions at community level. So let us start with the case number 1. So first case is 47-year-old male, history of fixation of fracture of right femur 1 year back, and presented to our hospital with non-union and first discharge from operated thigh for 3 months. He had osteomyelitis of right femur, and he was operated, implant removal and IND done by our orthopedic surgeon, and fixation of fracture was done on 21st January 2020. And first culture sent intra-op, which was suggestive of MRSA. So orthopedic surgeon started tablet linezolid and tablet clindamycin. So what happened after 3 weeks? Patient had complaint of generalized weakness, nausea, vomiting. Orthopedic surgeon advised CBC, serum creatinine. Serum creatinine was normal, but CBC, you can see on the right side, HB was 6.3, WBC 2300, and platelet 150,000. That is on 21st February 2020. Patient's pre-op hemoglobin was 12.7, post-op hemoglobin was 9.7. No significant blood loss from any other site as per history, and as discussed with orthopedic surgeon, he didn't expect any bleeding. And his TLC, platelet count, all were within normal limit in previous reports. So what is the reason of pancytopenia in this case? So it is linezolid induced bone marrow suppression. So what could have been done to prevent this? We could have checked his CBC. We could have advised him to come with CBC after 10 to 15 days of starting linezolid, and keep in mind about possibility of linezolid induced bone marrow suppression. It's not like that in every patient. If we start linezolid after 10 to 15 days, there will be thrombocytopenia or pancytopenia. But in certain patient, it can be there, and we have to have high index of suspicion, and we have to educate patient for the same to check his hemoglobin, WBC, and platelet count after 2 weeks of starting linezolid. So what else needed to be done? So this was for pancytopenia, but for MRSA, what can be done? MRSA is usually colonized in the axilla or skin or nasal flora. So in any patient in whom we isolate MRSA, it should be decolonized. So how we do decolonization? Mupirocin ointment, that is T-back ointment, in bilateral nostril twice a day, and 4% chlorhexidine in bath rather than having bath with normal body wash or soap for 7 days. So it will decrease the incidence of recurrent skin or any other infection with MRSA. So that is again prevention of MRSA and prevention of pancytopenia with linezolid. So here you can see on 21st February my notes history, and I have stopped linezolid. I have continued clindamycin in therapeutic dose and started doxycycline and started folic acid. We have not transfused the blood. And here you can see on 11th of March, next CBC, HP was 10.2, WBC 4,200, and platelet 3,90,000. So it's normal. So in follow-up, everything was normal, and as theoretically also, it is usually reversible within 2 to 3 weeks of stopping linezolid. So this was the case one.
Sir, I interrupted you. The one question is, other than linezolid, which medicine can cause pancytopenia?
Okay. There are many antibiotics, many medicine can cause pancytopenia. Even chloramphenicol can cause pancytopenia. So, but quite common, linezolid is quite over-the-counter prescribed drug by surgeons. So it has to be kept in mind.
Yes.
So,
yes.
Many other antibiotics have several other side effects. So I have just highlighted such important cases.
Yes. Thank you.
So next 2 to 3 cases are quite similar, but there are certain differences. So 60-year-old male and 60 kilogram of body weight, diabetic, hypertensive, presented to my OPD with complaint of vomiting and loose stools. Patient is was in regular follow-up. RBS on presentation was 220. Vital were normal. Mild dehydration was there on presentation. Blood pressure was normal, 110/70. So recent lab 1 month back, serum creatinine was 1.1, potassium was 4.4. So almost normal. Patient was on metformin 1.5 gram per day, teneligliptin 20 milligram per day, glimepiride 2 milligram per day, telmisartan 40 milligram, and amlodipine 5 milligram per day. So patient was prescribed ofloxacin onidazole combination, probiotics, and ORS-HA, and after 3 days, patient came with lethargy, nausea, and vomiting. There was no history of fever, and CBC was normal. So question is, what is the reason of current symptoms? So it can be due to sepsis, it can be due to acute kidney injury. And what we can do, what further test and why? So we can advise renal function and liver function test, so metabolic derangement, urine routine for any urine infection as patient is diabetic, and we can send cultures as well as if routine lab suggestive of sepsis. But CBC was normal, and we have seen the medication history. So why AKI? It's obvious that patient was dehydrated, poor over intake, and might have hypotension as well, secondary to loose stool, and he was already on antihypertensive, which can lead to prerenal AKI. So any angiotensin receptor blockers or ACE inhibitors like telmisartan in this case need to be stopped in case of sepsis or severe vomiting or diarrhea, any condition which leads to dehydration, to avoid AKI. And any other antihypertensive should also be given only after checking the blood pressure whenever patient is quite sick or dehydrated or having acute gastroenteritis. Otherwise, it will aggravate the AKI, particularly telmisartan group of drugs. So just this case was to highlight the importance of educating patient on stopping or checking blood pressure and taking telmisartan only after consulting with doctor whenever he is or she is severely ill or dehydrated or severe loose stools. So moving forward to next case, 60-year-old male presented with history of drowsiness, vomiting, fever, and rigor. And patient is known case of diabetes, hypertensive, CKD3, diabetic foot. Patient had history of recurrent hypoglycemia as well. And these are the ongoing medications: glimepiride 4 milligram per day, Nicardia 20 milligram per day, aspirin 75, and atorvastatin 10 milligram per day. RBS was 20 milligram on arrival, creatinine 2.3, WBC 11,200, rest everything is normal. So just on next investigation, what is your differential diagnosis? What is the reason of recurrent hypoglycemia? And after we get to this, then which are the safer oral hypoglycemic agent in CKD patient, or which are the OHA which are not renally excreted? So differential diagnosis, it can be sepsis, it can be hypoglycemia, it can be septic metabolic encephalopathy. And if sepsis, then what is the source? Patient is diabetic, it can be UTI, it can be pyelonephritis, or patient had diabetic foot as well, it can be skin and soft tissue infection. What is the reason of recurrent hypoglycemia? As patient has recurrent infection due to UTI or diabetic foot, and patient is on sulfonylurea, which is renally excreted. So it would be labile blood sugar. Overall patient HbA1c would be on higher side, but patient might have recurrent episode of hypoglycemia. So sometimes it's hypo or sometimes it's hyper. So next question is, which are safer oral agents in CKD patient or non-renally excreted OHA? So it is teneligliptin, linagliptin, glipizide, gluclazide, trepraglinide, voglibose or acarbose. So these all are safe and non-renally excreted oral agents, and it can be used safely. If we are using sulfonylurea like glimepiride, then we have to be very cautious and we have to educate the patient that anytime if symptoms occur, do self-monitoring of blood glucose, have some sugar sachet with them whenever hypoglycemia is there, but better to avoid such drugs to prevent such episodes. So now moving forward to next case, again 65-year-old male present with letharginess and vomiting for 3 to 4 days. So you can see almost all cases are elderly, all have diabetic or hypertension, and all present with some weakness, lethargy, vomiting, or some sort of complaint, but different different etiologies. So in elderly patient, we have to be very cautious while prescribing drugs. So on examination, GCS was almost normal, E3, V3, M6, little drowsy. Blood pressure was 160 by 94, rest all vitals were normal, systemic examination was normal. Patient has past history of hypertension, ongoing medication is telmisartan 40 milligram and hydrochlorothiazide 12.5 milligram, that is in combination, once a day. So what is the differential diagnosis of this patient? Again, it can be occult sepsis, it can be stroke, it can be hemorrhagic stroke or ischemic stroke, it can be metabolic encephalopathy. On clinical examinations, there was no focal neurological deficit, and on laboratory, we have found normal CBC and everything. So it turns out to be metabolic encephalopathy. So investigation, which investigation we have to do for immediate diagnosis, we can do ABG or VBG. We can advise CBC, RFT, LFT for further septic metabolic workup. CBC was normal, creatinine was 1.1, sodium was 118, potassium 4.2. So why hyponatremia? So diagnosis was clear, it was hyponatremic encephalopathy, but why? So it is due to thiazide diuretic, patient was on hydrochlorothiazide. And how it causes hyponatremia? It causes hyponatremia by inhibition of urinary dilution due to reduced reabsorption of sodium chloride in distal renal tubule. In contrast, loop diuretics like Lasix furosemide or torsemide, they do not impair urinary dilution and are not associated with reduction in serum sodium level. Usually, giving IV Lasix for 2 days, if patient gets dehydrated, you get hypernatremia instead hyponatremia. So this case again highlights importance of instructing the patient on subtle symptoms of hyponatremia and keep checking sodium on frequent interval every 3 or 6 months to detect subacute or chronic hyponatremia and preventing to present with emergency on acute and chronic. So now moving forward to case number 5. 20 8-year-old female recently discharged after elective full-term LSCS, presented with severe headache, blurring of vision, and convulsion. Patient didn't have any past history except major depressive disorder. So now we have encountered so many geriatric patients. So this is young female patient and postpartum, post LSCS. Blood pressure was 186 by 110, heart rate was 110. History suggestive of multiple panic attacks and high blood pressure during that time. Otherwise, there no baseline hypertension or not on any regular medication or pregnancy-induced hypertension. No such history was there. MRI brain was done, which was suggestive of press posterior reversible encephalopathy syndrome. And routine labs which signed CBC, RFT, LFT, urine routine, which were normal, no proteinuria as well. Fundus was done, it was normal, no signs of hypertensive retinopathy or no signs of raised intracranial blood pressure. So, moving forward to this case further, what is the differential diagnosis of this case, what further workup we can do, and which antihypertensive we can start? So, anyone in the panel or audience want to discuss? So, let us go ahead with answers. Differential diagnosis was eclampsia, press posterior reversible encephalopathy syndrome, and secondary hypertension. So it can be eclampsia, it can be press, or it can be secondary hypertension due to renal artery stenosis or pheochromocytoma. So what further workup we need to do to rule out all this and narrow down our differential diagnosis? So routine labs, CBC, creatinine, urine routine, SGPT, fundus, which we already done, bilateral renal arterial Doppler to rule out renal artery stenosis, 24-hour urinary metanephrine and serum metanephrine to rule out pheochromocytoma. And which antihypertensive to start in peripartum period? So it was peripartum patient. We can start labetalol, we can start nifedipine. In pregnancy or postpartum, we can continue with methyl dopa was started as well. So this was actually our patient. We have done renal Doppler, which was normal. We have sent 24-hour urinary metanephrine, which was also normal. And maybe patient may not have collected all 24-hour urinary metanephrine, or we don't know. But at that time we have done the workup, but it was negative. But patient continued to have such recurrent episodes of suggestive of panic attack and hypertension even after 6 weeks of pregnancy. So eclampsia, preeclampsia was out of the question. And then again her renal Doppler was done, and small adrenal gland, suggestive adrenal adenoma, pheochromocytoma was identified. Her metanephrine was tested again, which were high, and then she was operated for pheochromocytoma, and thereafter she was off all antihypertensive later on. So luckily we tested for all etiology in this case, but if unfortunately we have not thought of this differential, and we have not sent the urinary metanephrine and done renal Doppler, and after 1 month or 3 months, if they consult anyone else and they come to know, and notorious patients are increasing day by day, and if they just claim you that you have not checked this and we were not diagnosed, and it lead to unnecessary medication and unnecessary, we have wasted our 2 months with so many antihypertensive, then we could be in trouble. So on paper, even if patient is not affording, just try to explain them that it can be the possibility. It's your choice. You have, if you don't want to do, then it's fine. But I advise this. But don't neglect that it would be normal. Always think of secondary causes of hypertension, specifically when clinical history is suggestive of same. So in young patient, always do workup for secondary causes of hypertension. So next case is again elderly female with history of admission for anemia and receiving multiple blood transfusion in 6 months. Patient was admitted in outside hospital periphery with diarrhea and anemia and presented with breathlessness and following lab to our hospital emergency department. We have done blood gas, and this is the ABG. And below the ABG, you can see blood labs. ABG PS 7.24, PCO2 17.8, PO2 108, and bicarbonate 7.4. The rest abnormal labs you can see. Lactate 7.8. I will not dictate everything, but reading whole ABG is important. We can make out from this case. We can just In emergency, in 10 minutes, we can narrow down our differential diagnosis of even rare disease. This ABG highlights that. So serum creatinine was 3.2, protein was 6.7, albumin 3.2, globulin 3.5. So what are the abnormal findings in ABG? What is your differential diagnosis and what further test you would advise to confirm your diagnosis? So here you can see actual ABG picture. You can read date as well. So we have already dictated the ABG. Another abnormal labs, you can see hemoglobin is 3.7. So electrolytes are almost normal, potassium borderline high, chloride is quite high. So sodium 141, chloride 140. So it's usually not present in 95% of cases. So you can see anion gap is negative in this case. And another thing is ionized calcium is higher side on this case, 1.52. So this was the ABG picture I got from my ER team. And they have not marked calcium, they have not marked anion gap or chloride, although and they have checked the hemoglobin. So if you look at all this value and put it together, then you can get your diagnosis. So abnormal findings, we have dictated anemia, hypercalcemia, negative anion gap, metabolic acidosis, and high creatinine. Differential diagnosis, sepsis with hemodias, hemolytic anemia with hemodias, autoimmune hemolytic anemia with underlying lymphoma. It can be multiple myeloma as well. So what further test we would advise? We would advise calcium, phosphorus, uric acid, LDH, peripheral smear, urine routine, and further workup for myeloma or lymphoma. And bone marrow biopsy, cold agglutinin, CT chest, abdomen, all these things would be required subsequently, provided patient is affording. Otherwise, we have to send to civil government hospitals. But we have to do workup because it's not usual case. So it was autoimmune hemolytic anemia with underlying lymphoma. So moving forward to next case, now not elderly, not young, middle-aged female, 45-year-old, middle-aged male, 45-year-old male, present age with altered sensorium and seizures. History of acute gastroenteritis, 7 days back, patient took ciprofloxacin and metronidazole for same. Past history of diabetes, hypertension, venous sinus thrombosis. Patient was on warfarin 3 milligram per day, irregular follow-up, but last INR was done 2 months back, which was 2.2, and vitals on admission were E3, V3, M5, GCS, were BP 150 by 90, raised vital stable. And then we have done CT brain, which suggestive of left frontotemporoparietal hemorrhage. So it's basically IC bleed in young patient, diabetic hypertensive, venous sinus thrombosis on warfarin. And routine labs and IRR sent, INR was 6.5, routine labs were normal, platelet count, HB, everything was normal. So question is why IC bleed? BP is 150/90, not so high. So what are the reasons? So it can be uncontrolled hypertension, it can be microangiopathy due to uncontrolled diabetes, but in this patient, sugar, BP were controlled and high INR was there. So it is coagulopathy due to unmonitored warfarin treatment. So why INR was 2.2 2 months back, dose was not changed. Then why such high INR and why IC bleed? So history was 7 days back, acute gastroenteritis, patient took Cipro and Metro. So what to monitor when patient on warfarin and what to educate? So patient was on Cipro and Metro, both increase the serum level of warfarin and it may lead to increased bleeding risk. So we have to monitor INR and we have to educate and we have to self-educate ourselves and patient both while prescribing any drugs to the patient on warfarin treatment. So we don't need to remember everything. It's not rocket science. We can just install Medscape, Lexicom for check up to date for drug-drug interaction while prescribing multiple drugs, certain antibiotic, antifungal to patients on warfarin and adjust the dosage accordingly. And if possible, we can avoid such drugs. So now moving forward to case number 8, again elderly male presented with uneasiness, perspiration, giddiness followed by syncope. So this is also actual case I encountered 5 months back to our ICU at Velocity Hospital. Patient had pedal edema also for 4 to 5 days and past history of diabetes, hypertension. Patient had coronary artery disease as well. Status was post PTCA and patient is having CKD also for a few years. Baseline creatinine is 2.3 to 2.5 since last 2 to 3 years. On presentation, GCS was 14/15, heart rate was 40 per minute, blood pressure 110/50, respiratory rate 24, and SpO2 was 96%. So medication history, you can see medication history on the 2nd August 2021, Bisotep 5 milligram 1 in the evening, Silacar 1 BD, Pregason anti 1 HS, Febuxostat, then this seems dapagliflozin metformin combination, and this is Zucanom M. And on the right side, again, you can see on 18th of August 2021, Furacodnab and Ultrocin, and then Diter plus TusQDX and Dolo. And probably this was prescribed for pedal edema, I guess so. And so we have done further workup. RBS was 160. We have done ECG, suspecting acute coronary event as well. We have advised for echo, ECG suggestive of sinus bradycardia. So what further investigation we would do? So we would advise CBC, RFT, urgent blood gas to check electrolytes and troponin and 2D echo. Differential diagnosis, it can be acute coronary syndrome, it can be hyperkalemia. But why bradycardia? In acute coronary syndrome, it can be bradycardia if inferior wall or right ventricular MI. And in hyperkalemia also, it can be bradycardia, and it can lead to asystole, pulseless electrical activity, or asystole as well if it is severe. Why bradycardia? Because patient was on beta blocker and patient had hyperkalemia. So both contributes to your bradycardia. And why hyperkalemia? So hyperkalemia is due to CKD status as well as spironolactone. Patient was prescribed Diter plus. So what treatment we would give awaiting the results? So it can be hyperkalemia, it can be MI. Without further wasting time at 40 of heart rate and syncope, we would not wait, and we would give load with acute coronary syndrome, non-PAMI protocol. We would give dual antiplatelet and statin and heparin in loading dose, and we would give antikalemic treatment for hyperkalemia, that is glucose insulin drip, calcium gluconate, ascalin nab, and SOS soda bicarb after ABG. ABG is handy diagnosis, you can get in 5 minutes. So potassium, pH, bicarbonate, you can get in ABG immediately. So you can rule out hyperkalemia immediately. So even if hyperkalemia is not there, bisoprolol in higher dose in CKD patient can definitely lead to bradycardia. Echo was normal, EF was normal, no IWMA, TROP-I was negative, potassium was 6.4, creatinine same, static 2.4, HB 8.1, trace was normal. So we have given antikalemic treatment. After 4 to 5 hours, heart rate returned back to 60 to 70 per minute, and BP also normalized, and patient felt symptomatically better. You can see actual ABG on the right side. It was VBG actually, not ABG. To check for electrolytes, we don't need to do arterial prick. Venous prick is also sufficient because it hardly a fraction of millimole difference is there between ABG and VBG in electrolytes. Now, last two cases, again, last interesting case, 54-year-old male diabetic, no past history, complain of breathlessness on exertion for last 2 to 3 months. Consulted family physician, prescribed multivitamin and vitamin B12, and HbA1c was more than 9, so OHA was modified by family physician. Patient presented to emergency with perspiration and breathlessness at rest to our hospital. ECG done, suggestive of inferior wall MI, ST elevation in 2-3 AVR. Immediately patient was shifted to cath lab, and PCI was done, and medical management given for acute LVF, and patient was stabilized in 3 days and discharged on 4th day. So what could be the reason of breathlessness earlier for 2 to 3 months? So diabetic patient can present with silent MI and may not have chest pain. So always do baseline ECG and lipid profile of all diabetic patients to detect ischemic heart disease earlier and prevent developing acute coronary syndrome from ischemic heart disease. So many MI are missed in golden period, and many diabetic patients are presenting with sudden cardiac arrest if not diagnosed earlier. So take-home message was do baseline lipid profile and every year lipid profile and ECG in all diabetic patients, even if they don't have chest pain. 48-year-old male, last case, 48-year-old male non-diabetic diagnosed as extrapulmonary TB, started on anti-tubercular therapy, AKT. Patient had complaint of fatigue, nausea, and decreased appetite. Patient consulted family physician and prescribed multivitamin and symptomatic treatment. Patient presented with lethargy and drowsiness after 2 weeks to our hospital. So what is the further investigation you would advise, and what is the differential diagnosis? So we would advise CBC, RFT, LFT, ammonia, and RBS. And our differential diagnosis, it can be sepsis, it can be hyperglycemic hyperosmolar coma as patient is diabetic, and it can be ATT-induced hepatitis and liver failure as well. So icterus on examination was found and LFT were deranged. How could we have prevented it? So our purpose is preventing such fatal admissions. So we can prevent it definitely. We have to advise to check bilirubin SGPT baseline, and after 1 month and after 3 months of starting AKT, and educating patient that if you feel nausea, if you feel your appetite significantly decrease, if you feel, someone tells you that your eyes are getting yellow, that is quite later stage. At that time, usually patient presents to the doctor. But the subtle signs like decreased appetite, lethargy, nausea, then come to the hospital or consult your doctor immediately and check for your liver function test. So which patient are at increased risk of ATT-induced hepatitis or drug-induced liver injury, any drug-induced liver injury. So patient with concomitant hepatotoxic drug and patient presenting with liver disease like non-alcoholic fatty liver disease or cirrhosis of liver due to alcohol or any other reason. So we are already at increased risk of ATT-induced hepatitis. Patient is quite normal. Patient is just having child 1 CLD, no ascites, nothing. But patient develop TB and you start ATT, you don't educate your patient, then in 1 month the patient may end up with GI bleed, encephalopathy and a fulminant liver failure. So please do not take it lightly and educate your patients. So I try to summarize important cases, and I usually keep adding cases in this slide in my list whenever I encounter such interesting preventable cases. So take home message in single slide is monitor CBC while prescribing linezolid for more than 10 to 14 days. Monitor creatinine level before and after starting ACE inhibitor or angiotensin receptor blocker, that is olmesartan and telmisartan, losartan, ramipril, etc., which are commonly used. Hold antihypertensive or give them only after checking blood pressure in severe acute gastroenteritis. Hold ACE inhibitor or ARB in acute gastroenteritis or any sort of sepsis. Avoid sulfonylurea in CKD patient and educate for hypoglycemia. Monitor sodium in patient on thiazide diuretic, that is hydrochlorothiazide or chlorthalidone, and keep high index of suspicion or early symptom of subtle hyponatremia, subtle symptoms. And always keep in mind secondary causes of hypertension in young patients like pheochromocytoma, renal artery stenosis. Always check BP in both upper limb. Always check pulse in both upper limb in young patient, particularly to rule out Takayasu or vasculitis. Always check for drug-drug interaction, particularly with warfarin. Always check baseline heart rate before prescribing beta blocker, particularly in CKD patient. You get the patient is athlete, baseline heart rate is already 70 and you are prescribing high dose beta blocker, then it would be trouble for patient. Always check potassium before and after starting spironolactone. Be cautious while prescribing spironolactone in CKD patients. Do baseline ECG and lipid profile and keep high index of suspicion of IST and ACS in diabetic patient with just fatigue or exertional grade 2 or grade 3 breathlessness. And always check baseline SGPT bilirubin after 7 days at 1 month and 3 months of starting ATT. So that's it. I have finished my cases. If any questions, you can contact me on this number or email address. And I thank Gujarat State Family Physician Association for providing this wonderful platform and opportunity to spread this to provide this wonderful platform and discuss interactive cases. So if anything, any question, then we can discuss further.
Sir, which emergency at family physician, which emergencies at family physician level we can manage? And what are the emergency drug we can take at family physician level? Because our association is the MBBS Doctor Association and Family Physician Association.
Okay.
So at our level, which medicine is required as an emergency drug, and which emergency we can tackle at our level?
This cases keep high. That there are two different things. One is recognizing emergency and one is treating emergency. So to recognize emergency, I think you should everyone should keep have basic knowledge of ECG.
Yes.
So they can identify if end STEMI or STEMI is there. There are subtle changes. Clinical signs we have already discussed in several cases. Lethargy, fatigue, those subtle signs, and hyponatremia or high creatinine or hypoglycemia, all these present with such non-specific symptoms. So if you keep high index of suspicion, then you can advise electrolyte, advise creatinine, and call your patient back in half an hour or 1 hour. And then if you diagnose, then you can definitely treat in, or you can talk to your physician colleague and you can admit and treat in joint care. And regarding treating emergency, you should keep heparin, you should keep as dispirin, that is mouth dissolving tablet, not usually enteric coated ecosprin. So you should keep dispirin, clopidogrel, atorvastatin, all loading dose of these drugs, because rather than wasting time, patient will go to another doctor, go to another hospital and waste further 30 minutes, 40 minutes. We don't know whether they will go or they will just go home again. So you can, if you are suspecting acute coronary syndrome, you should keep loading drugs with you. If you are handling getting more cases of allergy or anaphylaxis, you should keep adrenaline with you. So adrenaline, amiodarone, all these are emergency drugs, and cardiac drugs for ACS I already told. So those should be kept with each general practitioner clinic. And ECG nebulizer, this in injection hydrocortisone, furacorter, duolin, vidacort, respiles, all these basic things should be there with every general practitioner.
Sir, one another question is anaphylatic shock and vasovagal shock. How we can differentiate and how we can manage it?
Okay, vasovagal shock is like your patient will give you history suggestive or syncope. Yeah. And ECG would be normal. You want sugar would be normal, blood pressure would be normal. You won't find anything else. So it's quite complex to confirm vasovagal shock or it is postural blood drop, blood pressure drop. You have to advise head tilt test, which is only few cardiologists do that head tilt test because it's time consuming. But anaphylactic shock is definitely you get some signs that after getting certain drug or after eating something, patient presents with some patient present with angioedema like lip swelling, facial swelling, orbital swelling. Some patient present with urticaria like lesion and itching. So in such patient, you can just give 200 milligram hydrocortisone or 4 milligram dexamethasone. You can prescribe 120 milligram Allegra, 10 milligram or 25 milligram Atarax, depending on the severity. So this basic treatment you can give and then refer to respective dermatologist or physician.
Yes, sir.
Vasovagal, interesting. I would just share another interesting case as you have asked for vasovagal shock. Just 2 weeks back, I got referred from my general practitioner friend one case. Every morning between 4 to 5, he gets sensation of micturition and he tries to wake up. And then he cannot go to the bathroom. He just gets giddiness and then he just fell down. And micturition he does in his clothes only. And patient was elderly male, known hypertensive. So we have checked for postural blood drop, it was normal. We have checked ECG, it was normal. We have done MRI angio to rule out posterior circulation stroke, it was normal. But then we have just done carotid sinus massage, attached the ECG leads, and patient had bradycardia immediately within 10 seconds of carotid sinus massage. So it was carotid sinus hypersensitivity. Very rare, but bad luck to the patient. So we have advised head tilt test to that patient as well, as it can be mixed syncope, not just carotid sinus hypersensitivity. It can be vasovagal as well. Yes. So head tilt test was strongly positive for significant drop in blood pressure on head tilt test. So we have advised, we have asked the patient various habits. He was keeping 2 pillows. He was sleeping quite with tilted head. Or we have just educated patient that you have to avoid anything which will press your carotid significantly, because pacemaker will not even help, as vasovagal syncope was also associated with carotid sinus hypersensitivity. And now it has been 2 weeks and patient is absolutely fine and doing quite well. So always clinical diagnosis is more important than any other test.
Yes, sir. Yes.
Oh,
Thank you, Dr. Vitrag Shah, for delivering the very informative and interesting case discussion. And we learned a lot of things that we manage many emergency cases of at our family physician level. And thanks to you, sir, for sparing your valuable time for us. And thanks to Zydus Pharma for sponsoring this webinar. And lastly, thanks to all the viewers for attending the webinar. Jai Hind, Jai APA. Thank you very much, sir.